Imagine you have a skin condition that is, making your tissue as fragile as delicate tissue paper.
Yeah, where it's tearing, it's bruising, it's basically just disappearing.
Exactly.
Yeah.
And you finally get to a doctor, right, hoping for some kind of relief, and they hand you a prescription for a heavy-duty cream.
Which you're thrilled about until you look it up.
Right. You take it home, you look it up, and the absolute #1 side effect of this cream, it severely thins your skin.
Which is, frankly, terrifying.
Completely terrifying. Today, we are diving into one of the most terrifying, yet fascinating, medical paradoxes in dermatology. Welcome to today's custom-tailored deep dive, curated specifically for you.
Our mission today is to figure out how this paradox actually works in practice, and we've got a really dense stack of sources to pull from.
Yeah, we're looking at clinical guidelines from the British Association for Sexual Health and HIV, the British Society for the Study of Vulval Disease, plus some deep pharmacokinetic reviews and recent medical journals.
And we are focusing all of these resources on a chronic, widely misunderstood condition called vulvar lichen sclerosus, or VLS.
And the gold standard treatment for VLS, this disease that notoriously thins the skin and erodes anatomy, is an ultra-potent topical corticosteroid, something like clobetasol propionate.
Which brings us directly to the core anxiety for anyone dealing with this diagnosis. I mean, potent steroids are infamous for causing skin atrophy.
Right, thinning. So our big question for you today is this. Can chronic topical steroid use actually mimic the tissue thinning caused by advanced lichen sclerosus?
Yeah, how do you even know if the treatment is curing the disease or, secretly making the structural symptoms worse?
Okay, let's unpack this. Because before we can evaluate the treatment, we need to look under the microscope at what this disease actually does to the human body.
Absolutely. So vulvar lichen sclerosus is an inflammatory dermatosis. The exact origin isn't definitively proven, but the clinical evidence heavily points to an autoimmune mechanism.
Meaning the body's own immune system is getting confused and attacking healthy tissue. But how does it do that?
Well, studies have found autoantibodies in some patients targeting something called extracellular matrix protein 1.
Extracellular matrix protein 1. That's essentially the biological glue that holds the structural layers of the skin together, right?
Exactly. So when the immune system attacks it, that foundational scaffolding begins to break down at a cellular level.
God, that sounds incredibly painful. What does that breakdown look like for the person actually experiencing it?
It usually starts with an intense, often unbearable itch, especially at night, along with severe soreness and burning.
And clinically, doctors are looking for those characteristic pale ivory white or waxy patches, yeah.
Right. They often form a really specific figure of 8 or hourglass shape around the vulva and the perianal area.
The clinical guidelines we looked at use a really striking, almost eerie term for the physical damage that follows. They call it a plastic doll appearance.
Yeah, that phrase describes the severe architectural loss that happens as the disease progresses. Over time, the local anatomy literally begins to resorb.
Like the labia minora can simply disappear.
Yes, you see midline fusion, where inflamed tissues stick together and basically heal into one another.
Which can lead to introital stenosis, right?
Right, a physical, restrictive narrowing of the vaginal opening.
The sources also mention it affects the clitoral area in a pretty extreme way, too. Like the clitoral hood can completely seal over.
Yeah, the hood becomes tethered and fuses shut, which completely buries the clitoris underneath the scarred tissue.
Wait, if the hood is sealed shut, what happens to all the normal skin cells that are supposed to, shed from underneath it?
Well, they get trapped. The skin cells, the keratinocytes, they continue their natural shedding cycle, but there's nowhere for them to go.
Oh, wow. So it just builds up.
Exactly. It packs the buried area with keratin debris, creating these incredibly painful pseudocysts.
That sounds excruciating. So you have the anatomy fusing and disappearing, and on top of that, the skin texture itself is changing dramatically.
Right. The guidelines describe the skin taking on a cigarette paper texture.
Because the structural collapse makes the skin incredibly fragile. It loses its elasticity.
Right. Instead of bending or stretching with movement, it simply breaks.
Like old brittle tissue paper, which makes it highly prone to fissuring, which is literal splitting open of the skin.
Splitting, yes, as well as erosions and purpura.
Purpura was a new term for me when reading the sources. They called it pathognomonic for VLS.
Right, and pathognomonic just means it's a specific hallmark sign that essentially diagnoses the disease on site.
It's the smoking gun.
Exactly. Purpura is deep bruising or bleeding underneath the skin. In VLS, the upper dermis undergoes a process where it is replaced by a highly ionized substance.
Let's pause there for a second. What is a hyalinized substance? Because it sounds like glass.
That's actually a really great way to think of it. The healthy, flexible dermal tissue transforms into this rigid, glassy, almost scar-like collagen.
And because it's so rigid, it offers absolutely zero protective cushioning for the tiny blood vessels underneath.
Exactly. The slightest friction causes those vessels to burst, resulting in massive, vivid bruising.
Okay, so painting the full picture for a patient here. Their anatomy is fusing, their skin is turning into glassy, fragile cigarette paper that tears and bleeds at the slightest touch.
Right.
And into this literal nightmare scenario, a doctor hands them a prescription for a heavy-duty, ultra-potent steroid. Knowing that steroids are notorious for thinning the skin, this sounds completely terrifying.
It does.
We really need to look at what these steroids actually do to a healthy person's skin to understand this fear.
What's fascinating here is the exact pharmacokinetic mechanism of topical corticosteroids. To understand why patients are so afraid, we have to look at the chemical reality of the drug.
Okay, break that down for us.
When you apply a potent corticosteroid to normal, healthy skin, it penetrates the cells and triggers the production of proteins called lipocortins.
I saw lipocortins mentioned in the reviews. What is their actual job?
They are the heavy hitters of anti-inflammation. They suppress the immune response that is causing all that damage. And this is but those same lipocortins have a secondary, powerful antimitotic effect.
Anti meaning against, and mitotic referring to mitosis, cellular division.
Right. So the drug is literally telling the skin cells to stop dividing and reproducing.
Wow. It brings cellular regeneration to a crawl,
Exactly. On top of that, the steroid inhibits epidermal lipid synthesis.
stopping the production of the fats and oils that keep the skin barrier plump and resilient.
Yeah, and the clinical studies demonstrate how quickly the structural compromise happens. There is a widely cited 1995 study by Lubach and Kietzman.
Oh, I remember this one.
Yeah, they applied clobetasol propionate, the exact ultra-potent steroid prescribed for VLS, to healthy normal skin twice a day.
And what?
After just 16 days, that healthy skin had thinned by roughly 15%.
Only 16 days to lose nearly a fifth of your skin's thickness.
Yeah.
That is incredibly fast.
It is. And it gets worse with overuse. When that epidermal lipid synthesis halts, you see a massive increase in transepidermal water loss.
So the skin's permeability barrier essentially breaks down, meaning it can no longer hold onto its own moisture.
Right.
I'm assuming that leads to some pretty severe long-term consequences if a patient uses too much of this stuff for too long.
We can look at extreme cases where patients used unregulated massive amounts of steroids over several years. Excessive use on the vulva specifically has led to extensive loss of subcutaneous fat in the labia.
Yikes.
Yeah, the tissue becomes a web of perineal skin covered in telangiectasia.
Those are the tiny, damaged, spider-like blood vessels you can see through the thin skin, right?
Exactly. And the pharmacokinetic data also warned about systemic absorption. The drug doesn't just stay on the surface if you use huge amounts.
Because the vulva is naturally occluded, right? It's enclosed by underwear and skin-on-skin contact.
Yes. Applying large amounts of potent steroids under occlusion forces the drug deep into the bloodstream. This can suppress the hypothalamus-pituitary-adrenal axis.
Meaning it messes with your body's natural hormone and stress regulation systems.
Right. It suppresses your natural cortisol production, which can lead to fatigue, blood pressure drops, and in really severe cases, Cushing's syndrome.
Okay, hold on. This completely validates the patient's fear.
It absolutely does.
If I have a disease that is systematically destroying my anatomy, making my skin thinner than tissue paper, and my doctor prescribes a cream that halts cell division, strips away the skin's natural fats, and is proven to thin normal skin by 15% in 2 weeks, how is this not just pouring gasoline on a fire?
I know, it sounds crazy.
Aren't we just accelerating the tissue thinning?
That extremely logical fear is what drives so many patients to abandon their treatment. It is known clinically as steroid phobia, but to see why that fear is misplaced in this specific instance, we have to look at the microscopic difference between a healthy person's skin and the skin of someone actively suffering from lichen sclerosus.
Here's where it gets really interesting. The whole paradox unravels when you look at the outermost layer of the skin, the stratum corneum.
Right. The stratum corneum is the body's protective barrier, the very top layer of the epidermis.
In normal, healthy vulvar skin, the average thickness of this layer is roughly 170 micrometers, a tiny microscopic fraction of a millimeter.
Right. But in skin under attack by lichen sclerosus, the autoimmune process triggers a massive abnormal buildup of keratin.
This is called hyperkeratosis, right?
Yes. The stratum corneum doesn't thin out at all. It actually thickens to a staggering 1,200 micrometer.
Over 7 times thicker than normal. That is wild.
Microscopically, the disease has constructed a massive, unnatural shield of dead keratin cells on the very surface of the skin, even while the layers underneath are turning into that fragile, glassy, hyalinized tissue we talked about earlier.
That completely changes the visual. Wait, so it is less like driving a bulldozer over a delicate flower bed, and more like using a heavy-duty sander on a massively thick, unnatural callus.
That is the perfect way to conceptualize it. The steroid's antimitotic effect, the very thing that thins normal skin, is suddenly an advantage.
Because it's targeting and breaking down that 1,200 micrometer hyperkeratotic shield.
Exactly. It's trying to return the skin to its natural 170 micrometer baseline.
So the thinning side effect is actually doing the heavy lifting of the treatment. But what about the delicate anatomical structures themselves, like the labia minora and the clitoris?
Well, the sources mention something about different tissue types absorbing the drug differently. The vulva is a highly complex anatomical region.
Right, it is not just one uniform type of skin.
No, it's a blend of keratinized skin, mucosal membranes, and modified mucosal membranes.
And those modified membranes, the ones that make up the labia minora and clitoris, which happen to be the primary targets of the disease, they have a really bizarre reaction to the steroid.
They do. They are inherently resistant to corticosteroid-induced atrophy and telangiectasia.
So even when exposed to ultrapotent steroids, these specific tissues simply do not thin out the way the skin on your arm or thigh would.
Nope. They just don't.
That is wild biological armor. Do we know how that works? Why would one patch of skin ignore a chemical command that another patch of skin completely obeys?
The cellular mechanism isn't fully decoded yet. Researchers suspect it's a combination of the mucosal tissue's unique regenerative properties paired with the intense local inflammation of the autoimmune disease itself.
So the disease is constantly driving hyperproliferation at the cellular level.
Right, which acts as a powerful counterforce to the steroid's attempt to halt cell division.
Wow, so the severe inflammation of the disease is actually buffering the most dangerous side effect of the medication.
Yeah.
The body is fighting the drug, and the drug is fighting the body, creating this perfect standoff where the skin is protected.
Which brings us to the clinical reality. Because we can theorize about biological armor and 1,200 micrometer shields all day, but we really have to look at what actually happens to patients who use these super potent steroids for decades.
Right, because VLS is a lifelong condition. You don't just use this cream for 2 weeks and walk away.
No, you don't.
So if the steroid only works perfectly on this 1,200 micrometer shield, what happens after years of use?
Well, let's look at the histology, the actual microscopic tissue samples from long-term users. There was a critical study following women who used twice-daily clobectazole propionate over a 22-month period.
Almost 2 full years of applying an ultra-potent steroid twice a day.
And the biopsies taken at the end of those 22 months showed zero histological evidence of skin atrophy.
Zero. None at all.
None. And going back to that Lubac study from 1995, the one that found 15% thinning in healthy skin after 16 days, that same study revealed something incredibly reassuring about the reversibility of the drug.
Oh, right. What happens when they stopped or slowed down the applications?
When patients spaced out the application of the steroid to every 10th or 14th day, the 15% thinning entirely reversed.
The healthy skin bounced right back to its normal thickness.
Exactly. The drug's thinning effect from a single application only lingers in the tissue for about 3 days.
Which makes the long-term clinical guidelines make so much more sense. The major dermatology organizations in Europe and the UK actually agree on a very specific way to taper this medication to keep the disease at bay without overloading the skin.
Right. The protocol is designed to induce remission and then maintain a gentle holding pattern. You start with a tiny amount, just a pea-sized dab, about 0.33 grams, applied once daily for 4 weeks.
Then you step it down to every other day for another 4 weeks.
And finally, the long-term maintenance phase, which is applying that same pea-sized amount just twice a week, indefinitely.
And based on what you said about the drug lingering for 3 days, that twice-weekly schedule is perfectly engineered.
It really is.
You apply it, it suppresses the autoimmune attack for 3 days, and just as it's wearing off, you apply it again.
It maintains a low-level anti-inflammatory presence, keeping the disease suppressed without constantly hammering the cells with antimitotic commands.
You know, context is literally everything in medicine. If you're ever prescribed a strong medication for a chronic condition, it is so crucial to ask your doctor about the difference between a medication's side effect on healthy tissue versus its effect on diseased tissue.
Absolutely. A steroid acts completely differently on a thick, inflamed VLS plaque than it does on the healthy skin of your forearm.
We have to talk about the alternative, though, because if a patient doesn't understand that context, if they get scared and stop using the cream halfway through, that 1200 micrometer shield comes back,
Yes, the architectural destruction resumes and they open the door to a much darker outcome.
a cancer risk.
Right. Chronic, uncontrolled inflammation in vulvar lichen sclerosus causes continuous oxidative stress at the cellular level. This leads to damage at the molecular level, specifically lipid and DNA peroxidation.
Where the fats and genetic material inside the cells are essentially degraded
Yeah.
over time.
Exactly. And if left unchecked, this chaotic cellular environment carries a lifetime risk of developing squamous cell carcinoma, which is a type of vulvar cancer.
And the estimates place this risk between 2 and 6%, right?
Yes.
But the data shows that regular, appropriate use of topical steroids drops that risk of malignant progression to near zero.
Right. By avoiding the steroid due to an unfounded fear of skin thinning, a patient inadvertently allows the disease to progress toward permanent anatomical scarring and a heightened risk of cancer.
The steroid literally stops the chaotic cellular turnover that creates the microenvironment for tumors to grow.
It does.
So what does this all mean? Let's bring all these pharmacokinetic reviews and clinical guidelines together for you. We started this deep dive with a really terrifying paradox. Can chronic topical steroid use mimic the tissue thinning of advanced lichen sclerosus?
Right. Are doctors treating a skin thinning disease with a skin thinning drug?
And the evidence gives us a definitive no.
A resounding no.
Because vulvar lichen sclerosus creates that massive 1200 micrometer cellular shield of hyperkeratosis, the steroid has to chew through all of that excess material before it ever threatens healthy tissue.
Exactly. And combine that with the natural biological armor of the vulvar mucosal tissues, which inherently resist steroid-induced atrophy, and the medication is doing exactly what it was designed to do.
It halts the inflammatory attack, stops the anatomical fusion, and prevents the DNA damage that leads to cancer.
The drug isn't causing the thinning, it's the only thing standing in the way of it.
It really changes how you look at warning labels. I mean, when you understand the microscopic battlefield of a disease, the treatment that sounds like a paradox suddenly becomes a perfectly engineered solution.
It is a brilliant mechanism, but, reviewing all this data leaves me with one final unresolved puzzle, something for you to think about after we wrap up today.
I love these. Lay it on us.
Well, we know that the modified mucous membranes of the labia and the clitoris possess this inherent natural resistance to corticosteroid-induced atrophy.
Yeah.
Under intense steroid exposure, those specific cells simply ignore the chemical command to thin out. What exactly is it about their genetic or cellular makeup that grants them this biological armor?
Oh, that is the million-dollar question.
Right. If medical science could isolate that exact mechanism, if we could unlock the secret of why those mucosal cells are immune to atrophy, could we one day replicate it?
Wow.
Imagine developing a synthetic compound that mimics this mucosal resistance. We could use powerful, life-changing steroids to treat severe eczema or psoriasis on the rest of the human body without ever having to worry about skin thinning again.
That would completely revolutionize dermatology as we know it. The very thing that makes this disease so complex might just hold the key to the next massive medical breakthrough.
It just might.
Until then, keep questioning the paradoxes and we'll catch you on the next deep dive.